burden of trying to address some of these core issues when it comes to looking at technological advancements to try to access healthcare. All these are sort of stopgap measures. The whole telemedicine, patient portal, shorter visits, everything is just a stopgap measure, but it fails to address the underlying core issue of physician shortages, for that matter. And so, what is ACP recommending, if anything, to help to offset those physician shortages?
The college has always maintained the importance of framing general internal medicine as a very rewarding career that is. Please understand that yes, there are frustrations, there are administrative burdens. I think you have 3 general internists here who would not have chosen another profession, and I could say that from 40 years of experience. So it is the right way to practice medicine, and one that none of us would like to give up. I agree with you, we need to expand the pool, but in doing that, I'm not sure that just expanding the number of general interns will address some of the issues that we've discussed today, because it's not as if people will come along and enable us to see 5 patients a day rather than 10 or 15. That number, 10 or 15, is determined, unfortunately, by reimbursement policies, by billing and so forth. So we need, my take on the shortage of primary care physicians is that it really addresses the public's concern. I'm not sure it's a direct way to address the burden on individual physicians.
So I can take a crack at it again. I think it's all interrelated. I mean, I think part of the physician shortage is that people don't find the meaning in their work, that they're training under physicians who are burned out, and why on earth would they want to do that when their mentors are burned out? And their mentors are burned out. That's what we're trying to figure out, is exactly what are the root causes of this burnout and address them. And again, we have this multi-pronged approach because like most things in the world, it's complicated and there's a lot of contributors to it. And so if we can improve practice efficiency and get rid of some of these administrative burdens, hopefully we will lessen burnout. If we can address things regarding physician compensation in some of the cognitive specialties, people will have an easier time paying. One of the big elements related to burnout is the amount of debt that someone has. And so if we can tackle that, again, maybe people are going to burn out less. So I think it's really fairly complicated, and that's why we have to tackle it on different levels. It's not as simple as teaching people the individual resilience, but that needs to be a part until these are big, huge systems changes that we're talking about. And those are going to take a while, and while we're working on those, we need to address the individual piece so we don't have other trainees, other colleagues leaving the practice early or, heaven forbid, committing suicide. So I know sometimes people key in on that individual piece and say, you can't yoga your way out of this, and we totally realize that, but again, we need to do something while we're tackling it at the larger level.
And just to add on that, I think ACP feels extremely strongly that patient access is an incredibly important principle, and that we want to continue to do things that improve patient access to internists, but patient access throughout the healthcare system. And this is where creative thinking and transformative thinking really comes into play, but you need the clinicians at the table, just like you need the patients at the table, and that digital health and telemedicine, again, you need the combination of a human solution and a clinically, reasonable solution. You can't just have the technology companies developing their solutions in a vacuum. And one of the things, speaking of telehealth, because that is a nice tool that may be used to improve access, but you have to do it right. And that telehealth revolution is really currently being driven by payers and employers, telehealth companies, and consumers. But clinicians haven't been at the table, I don't think, in the way that they should be. So I think there really is a sweet spot here where we need to redesign the way that we do work, and team-based care is a big thing. So we have a paper that we wrote with the National Academy of Medicine around the importance of team-based care, and really thinking about what are the qualities of what are the key features of high-quality teams, so that everybody in a practice or on a clinical team, including the patient, by the way, should be on the team, is practicing at the top of their license and brings their specific expertise to the table.
I'd like to expand on what Dr. Smith was saying. You need the patient at the table, and certainly the physician at the table. You also need the practice leadership, the hospital administration, the corporation that is running your practice, if it's not an individual self-owned practice. These teams are often an expense. These teams are often part of the overhead, but they are so important to have a social worker in your practice to whom you can refer some problematic issues. And that will enable you to move on in a much less harried way than would be the case if you were fighting the battle alone. You need educators so that they can step in and do some of that very time-consuming instruction about how to take your insulin, about how to use your inhalers. You need a pharmacist in your practice who can really help the patient understand the intricacies of taking those 12 prescriptions in one day. Those tasks traditionally have fallen to the physician, and that is a real dissatisfier. So an effective team, which again will make well require resources, it doesn't always pay for itself, is really part of the solution.
And it's not just to take that sort of burden off of the physician. Most of those team members do it way better than us, and there are studies that show there are better outcomes with this team-based approach, and there are studies that show that physician satisfaction and self-efficacy, because you do it better. One of the challenges with taking care of chronic diseases is you can't really see the impact, or it takes a really, really long time to see the impact of the work that you're doing. But when you do it better, because you have the right people on your team, that satisfaction goes up because you actually are doing it better. So it's not just the burden of the work, but it's the quality of the work.
Can I just make one more comment about the teams? Because, it's wonderful if you're practicing in a setting where you have all this expertise available at your fingertips and you have the resources to add them. But I was speaking out in West Virginia about teamwork to a bunch of safety net hospitals, and they were saying, we don't have that expertise, we don't have these people. And that's when you start having to get really creative and thinking about community health workers. You think about the new article that just came out about hypertension and having pharmacists in barbershops, for instance. Partnerships around diabetes with YMCA. A team doesn't just have to happen within the context of a practice. So this is where creative thinking and the innovation challenge and hearing from the next generation, we just need to think bigger and broader. We can solve these problems, but we have to do some creative problem solving.
Is there any